Dr. Chablani, I want to shift over systemic therapy, metastatic hormone sensitive. We have a lot of regimens. So how do you make sense, or talk to the patient about you've got 9 positive trials, doublets and triplets, and quadruplets? Oh my, right? Where do we go with this, right? How do you guide a patient through this?
So very relevant question. It's great to have options. First of all, I'll say it's great to be able to discuss different options with patients and throw this in their court a little bit. But I do, anyone with visceral mets, liver mets, lung mets, I do go for the triplet, and I recommend that because we know that liver mets are an adverse prognostic factor, lung mets a little bit less so. High volume, as I was talking about, that floor disease or lots of bony mets on PSMA PET or conventional imaging, I'll recommend the triplet. Then for people in that gray zone with like 3 to 5 bone mets, I will talk to them about ADT plus ARSI versus the triplet, and say that we don't have great randomized data between doublets and triplets. We do know that we're not giving ADT plus docetaxel anymore. That is no longer a standard of care. But between ADT plus ARSIs and our different, ARSIs and abipred and the triplet, we don't have that randomized data yet. So they're both good options, and it's up to them if they want to be a little bit more aggressive. As I mentioned before, I also look at the PSA as a data point. If it's like lots of bony mets, but a PSA that's like 5 or 3, a low PSA, I'm thinking there's more of a aggressive biology here. I look at the prostate biopsy, intraductal carcinoma, many cores with intraductal carcinoma. That's an adverse prognostic feature. And then I also look at my NGS. So patients with high-risk tumor suppressor gene mutations in 2 out of 3, P10, TP53, and RB1, if they have 2 out of 3 of those, I'll also think that this is more of an aggressive variant prostate cancer and needs something more than just hormonal therapy to augment their response. So with the NGS, the PSA, and I mentioned before as well, the age of the patient, if they're in their 50s, if they're robust, and I'm like, why are they having all these mets everywhere and they're so young? Like, let's give them the triplet, let's augment treatment up front to delay time to castrate resistance.
Yeah, and then maybe we can share with the audience, we saw STOPCAP today, right? Can you give an overview of that data? Because it's feeding right into this idea of treatment selection.
Yeah, so the STOPCAP analysis looked at, I think 11 trials in the metastatic castrate-sensitive prostate cancer space, and it was a meta-analysis that collated all this data. And basically, it did tell us what we know, that ADT plus ARSI is beneficial in terms of PFS and OS in the majority of patients, and we're on the right track with this. But there was a subgroup of patients of 75 and above where it seemed that they didn't benefit as much from ARSI, and particularly abiraterone prednisone. So I really liked Dr. Dorf's commentary where, we should, in our older patients that have more comorbidities, more cardiac disease, perhaps are less frail, we really should be thinking about which ARSI to use. And because we have abiraterone prednisone, but then 2 apalutamide, enzalutamide, and maybe darolutamide based on ARANOTE results, we really need to be tailoring our choice of ARSI to the patient in front of us based on the drugs, other drugs that they're on, drug-drug interactions or other comorbidities, performance status, and using a personalized approach to that patient than just going to this is the one I always use.
Yeah, I think bringing up ARANOTE is so important, right? Because we're all used to the triplet therapy. We have ARASENS with darolutamide, ADT, docetaxel, but now we've got a data set kind of ex-US, right? Showing darolutamide doublet, giving the kind of results you'd expect. No real surprise, right? It works to do darolutamide ADT. You don't have to have the docetaxel to see meaningful benefit. I would follow up, the point that you made is correct. There's no role for docetaxel ADT doublets anymore, but the reason is not because it's a bad combination. It's because if someone can get through ADT dosi, why would you not give Dara or Abby after, right? Anybody who's getting dosi should get a triplet. There's no rationale for a doublet, I think is the point. Evan, what would you say? I mean, where does ARANOTE fit in now?
Yeah. I think the ARANOTE study was useful and helpful. I mean, I've heard various people take different takes on it. I think you brought up the key issue that it was done outside the United States, and people said, there's a lot of people that are really focused on the fact that, a doublet at minimum is the standard of care. How did these patients get less than a doublet? Well, not everywhere in the world is there great access to all of these agents, okay? And I think we have to recognize that. And so I do think that the data that was gleaned from that study is important. When I look at that data and I say the RPFS benefit is very significant, yes, the OS data is not yet mature, but it looks very similar to what we saw in ARCHES with enzalutamide, where we saw a significant RPFS benefit, the curves, the hazard ratio, all of that looks pretty similar. And then later we saw an overall survival benefit. From my perspective, and again, I'm not a regulatory agency, but from my perspective, I don't really see a difference in whether I need to see overall survival to be able to give a doublet with ADT darolutamide. Now, third-party payers and regulators may see a difference right now, and they may not want us to do that. But I think it's going to eventually read out with very similar overall survival data, and I think that's helpful for the exact reason that was just kind of discussed in STOPCAP. Because, the more advanced age a patient is, the shorter the anticipated lifespan. I think we have to be honest with that. And although a doublet is standard or a triplet is standard, there may be patient populations that have a lot of comorbidities and be of advanced age where agents like abiraterone have a higher cardiovascular risk. Enzalutamide may induce more fatigue. The seizure risk is tiny, but it may induce more fatigue and restless leg syndrome and risk of falls, and coming with falls are hip fractures. Those things have major morbidity risk. The one thing I'll point out in ARANOTE that was most helpful to me, so I'm very glad and grateful that the study was done, is I was really surprised to see that the treatment arm actually had less fatigue than the control arm. And I don't know what other oncology study you see where that occurs. There was more treatment-associated discontinuations on the trial for the control arm than for the treatment arm. So for me, I would love it if you have that option available as a doublet in the future. That's just my 2 cents.
Yeah. Well, all right. So we know in the surprising real-world data in the U.S., the majority of patients getting darolutamide somehow don't get docetaxel, right?
That's because of the label. So how the label is written is that you can start the doublet with ADT darolutamide first and then add the docetaxel later. Because let's be honest, that's what most of us do when we do a doublet and we're going to add the triplet later.
I start this today, Dosi comes in.
Right, the Lupron gets started, the ARPI gets added in there once the insurance clearance comes through, and then maybe a little bit later the docetaxel gets added. So sometimes, for whatever reason, the docetaxel may not be added. I don't know.
Can I add something to that too? A really compelling trial that will answer this question too is the CCTG trial, that triple switch that just opened 2 weeks ago. So basically it's dealer's choice ADT ARSI, but for those patients that don't have the optimal response. We always see these patients that don't hit less than 2 on their PSA. We think they're probably going to have castrate resistance sooner. So I think it's an easier discussion to have with patients. Hey, let's start with ADT ARSI. You're going to feel much better in a couple months, right? Maybe even sooner. And then when we actually get more information, like based on your PSA kinetics, maybe even genomics like the P10, the TP53, and the RB1 loss, and maybe even SPOP is another one that shows that you have a more indolent course.
Right.
I think that's going to be incorporated in the future of precision selection here.
Can I just add, I'm glad you brought up that study. The CCTG, SWOG, triple switch collaboration, I think is phenomenal, because we have to recognize the fact, I think everybody here knows, but I'm just going to bring it up, is the fact that all the triplet therapy studies had a control arm of ADT docetaxel. And we just got done saying that the NCCN guidelines in the United States don't recommend that. They use it a lot more in Europe, but in the United States, our doublet is not ADT docetaxel, it's ADT plus ARPI.
Well,
There
it
has
was
no-
when the studies were designed.
Right, right. But we don't have robust data, and I think we need that robust data to show that you really need the docetaxel, right? And I think it's really good to start with a patient population that's PSA doesn't go undetectable, because we know going undetectable, you could drive a truck through those curves if you don't go undetectable versus going undetectable. And then there's the Alliance study where they're really intending to look at those with the tumor suppressor gene alterations. You got to have a P53, P10, or RB alteration. That being said, I don't think it's part of the eligibility, but they're doing next-gen, they're doing sequencing, they're doing immunohistochemistry, they're doing testing, I believe, on everyone. And then they're going to splay that out. And that's a key question in that study. Do those patients preferentially do better with docetaxel? There's some preclinical data. We know they have a worse prognosis. So these are the things of the future where the control arm is a doublet with an ARPI. And I'm glad we're doing it.
Yeah, that's a clean study. That's with apalutamide, right? But the TP53 and the RB1 is more of a strat factor. And so, but we're looking forward. I think they're answering two different questions, but similar population.